Vascular pain. We don't think about vascular pain. What we do is we think about those ugly veins on our legs, and we see a lot of things. So let's talk to someone who's a real expert. She is a medically trained physician that specializes in vascular health, and her name is Dr. Vasana Cheanvechai. I thought I had it. We're going to help me with that again.
Cheanvechai.
Right, Cheanvechai. Thank you. Dr. Cheanvechai is someone who is extremely enthusiastic about being a vascular surgeon because she really wants to help people, not just cosmetically, but because there is pain involved. Why don't you tell us a little bit about what a vascular surgeon does first, and then we can go from there.
That sounds great, Anita. Thank you so much for having me here today. Vascular surgery encompasses all the blood vessels in your body. So any problems with the arteries, which bring the blood flow from the heart down to the rest of the body, or any problems with the veins, which bring the blood flow back up to the heart and the lungs. And so you can have carotid disease, which means blockages in the neck arteries that can lead to strokes. Or you can have aneurysms in the belly, an aortic aneurysm, or in the chest, and those can rupture. You can also have blockages in the leg arteries, and that can lead to something called PAD, or peripheral arterial disease, and that can cause leg pain. Or you can have trouble with your veins. Again, the veins bring the blood flow up, and then you can have pain in the legs as well as the varicose veins. And so what a lot of people think with varicose veins is that it's just purely cosmetic, and it really isn't. People have a lot of discomfort when they have vein problems. They have heaviness in the legs, achiness, tiredness, swelling. Some people have burning and itching. And a lot of people will think, oh, it's just that I've been up on my feet. Well, there really is a reason for that, and there's a lot of things that we can do to help that. When people come in to see me and they start complaining of these kinds of symptoms, we investigate that further and make sure that their veins are in good health. Because if they're not, then we prescribe different things. There's different treatment options. We can treat the broken veins, and the people feel like a new person the next day. I mean, it really is amazing.
So what actually, Dr. Cheanvechai, what actually is the cause of some of this? I mean, is this hereditary, or is this something that someone could prevent?
Well, with the artery disease, there's a lot of hereditary factors. Age also is a factor, cholesterol, all the things that you normally hear about with heart disease, high blood pressure, diabetes, cholesterol.
I'm sure smoking.
Smoking is a big one. Now, with the veins, there's a lot of other things that are involved as well. Again, hereditary with varicose veins, age. But if you've ever had any kind of job where you've been on your feet all the time, or sitting for long periods of time, anything like that will start to break down the veins. Also, pregnancy, because of all the weight, puts pressure on the veins. So you'll see a lot of pregnant women will have big varicose veins that a lot of times don't go away after childbirth, and we need to treat that afterwards as well. The worst thing that can happen with vein problems is that if it's so bad, you can end up having wounds or ulcers or sores in your legs. And a lot of people walk around with these sores. They don't know what the cause is, and they live with it for years and years and years until they come to either a wound center like we have at Imperial Point, or see a vascular surgeon and find out, oh yeah, it's because your veins are broken. We close up the veins and the wound heals up within weeks.
So because I'm standing here at the radio station and probably will do this for the next 3 hours or so, you're saying I should be, and I'm not having problems or pains with my legs at this point, but I probably should be wearing compression stockings, shouldn't I?
Yes, that is a great preventative measure. And so compression and elevation is the mainstay of treatment for varicose veins or venous insufficiency. And what the compression does is that what's going on is that the blood is having a hard time getting out of your legs, because inside the veins are things called valves that help to push the blood out of the legs. So as you walk, your muscles pump, trying to squeeze the blood up, but because of the gravity, the veins need the help. So inside, the valves close, and then the muscles pump again, squeeze the blood up a little bit further, the valves close. Eventually, it makes it up to the lungs and the heart. When you've been standing all your life, sitting all your life, being stagnant, those valves will start to break down so that they will, in essence, leak a little bit instead of getting efficiently the blood out of the legs. So when you wear special compression stockings, those help to gradually push the blood out of the legs all the time. The other thing that you should do is be as active as possible. Keep that muscle pump activated. Keep the blood circulating. Yes.
I'm marching to the tune of her speaking. That's what you're saying, yes, right?
And then elevate your legs as well. And so when people come home, a lot of people will think, oh, I get home, it's been a long day at work, I just want to put my feet up. Well, there's a reason why it feels good. It's because you probably have vein problems and the blood has been pooling down in your legs all day long. And then when you get home, you elevate it to help get that blood out of the legs, where you could feel good all day instead of having to come home and put your legs up if you just wear the compression socks.
I know that on airplanes,
Yes.
I've been told, of course, to stand up, and I try every hour at least to get up and walk around, but I suppose I should be wearing compression stockings there, even though I'm not really having... So you don't have to have problems with your legs.
No,
it's preventive,
it's
isn't
a
it?
very, very big preventative measure. And I wear compression socks anytime I fly. So what I tell my patients is that anybody can get a blood clot in their legs if they stay stagnant long enough. So especially any flights over 2.5 hours, you have to make sure you're well hydrated. Try to keep your legs moving. You can just do, and they have this sometimes in the magazines on the airplane, just circles with your ankles just to keep the muscles moving and keep the blood flowing, because there's not always time where you can get up and walk up and down the aisles of the plane. But it is a very real problem, and all the airlines know it because the stewardesses are on their feet all the time or sitting all the time as well. And they recommend doing these exercises for long international flights to try to prevent any blood clots from happening.
Well, my guest is Dr. Vasana Cheanvechai, and she is a vascular surgeon, and it's being sponsored by Broward Health Imperial Point. If you would like to make an appointment, you can call browardhealth.org, and that's /BHIP, or you can call 954-338-3021 for an appointment. So let's not say who, but let's say what is entailed in fixing veins. Let's go from the spider veins, which maybe is only cosmetic, into something more serious.
Yeah, so the spider veins are really just those little purple veins that people see on their legs. Sometimes they're purple, blue, or red. And again, those are related to family history, and they are a little bit more cosmetic. Sometimes they can be painful, and sometimes they can bleed. So those are the two things that you want to look out for. Those are usually treated with injections, and there's different types of medicines for injections. We've come a long way with the types of medicines. In the past, they used to use saline. Now they use some medications. One's called polydocanol. So there's a lot of different medications that people can use. There's also a surface laser that some people can use. It's sort of almost like removing a tattoo. So it's a special laser that some doctors have in their offices to do that for the spider veins. Any kind of injection procedure, that's called sclerotherapy, and that's injecting any kind of medicine or fluid into the vein. And what that does is it causes the vein to collapse on itself, and over time, it will just start to disappear.
Where does the blood go when that happens?
It just sort of dissipates into the tissue around there. So you're collapsing the vein. And then over time, and a lot of times it'll take multiple sessions to get that vein to shut down completely. And then the one thing that you have to remember if you're doing the spider veins for cosmetic reasons is that, as much as you get injected, you're not going to have legs like you did when you were 12. So,
oh, darn.
So most of the time people will see a good result, about 90% faded away. But there's lots of other things too you can do to help that along, and not get in the sun as much, things like that. A lot of people try to get in the sun to cover up the veins. But when you're going through the treatment, you don't want to be in the sun. Now, if you have the big ropey veins, a lot of times some people will have them. They don't bother them at all. Sometimes they will be very painful. Those we actually will take a look at, and we'll do an ultrasound. And so what we do is we'll do an ultrasound in our office. We'll look from the groin all the way down to the feet. We look at both systems of veins, because remember, there's a deep system in your body as well as a superficial system. And if the valves are broken in either one of those systems, it puts pressure as the blood pools down in the legs, and it causes those veins to bulge out. The ultrasound's very easy. It's just done in the office. There's no poking, there's no sticking or anything like that. And that helps us to localize where the valves are broken. So depending where the valves are broken, the treatment options include, the old school is vein stripping. And if you've been through the vein stripping before, you know that it's as brutal as it sounds. Basically, we just make 2 incisions and pull that vein out. And we don't really do that very much anymore because of all the newer procedures that are available. So the newer procedures are treatment within the vein itself. And what we're trying to do is collapse that broken vein down. And when we do that, it reroutes the blood up into the normal vein system to get the blood flow out of the legs. Because remember, when the valves are broken, the blood's going to go wherever the path of least resistance is. And so if the valves are broken, it likes those broken veins and it'll just pool in your legs. So our goal is to shut those veins down. There's two ways to do that. You can either use what we call radio frequency ablation, which is almost like a heating of the vein to get it to close down, or endovenous laser therapy, which is a laser fiber that also closes the vein down. Both procedures are office-based procedures. You don't need anesthesia for either one of them. You do get some local anesthesia, meaning some little pinpricks along the pathway of the vein to numb the area up. And then afterwards, you are required to wear the compression socks. And generally, you have to wear them for a good 7 days. Everybody has different protocols. Our protocol is to wear them for 7 days straight. We do check you with another ultrasound at about the 3rd day, and then we check you at 1 month and 6 months and once a year after that. Because remember, when you have vein problems or any vascular problems, it's something that will always be with you. And so we're always checking, making sure nothing else is breaking down, nothing else is happening. So when I touch a patient, they end up being my patient for their lifetime, whether they like it or not.
I'm sure they're going to like you. Dr. Cheanvechai has so much personality, and what I like about you is you smile a lot. And a lot of doctors don't do that, so I applaud you for that. Well, let's just go into people who are diabetic.
Yes.
This could be very serious, couldn't it?
Yes. Diabetes really has a root in a lot of different parts of your body. You know, there's so many complications involved with diabetes. You can have eye problems, you can have vascular problems, you can have heart problems. The problems that arise in the vascular world is that the diabetics, their arteries will get very brittle. And so they will have disease in the very, very small arteries, as well as some of the arteries in the legs. When that happens, they'll build up blockages in the leg arteries, and they can have problems with pain with walking. A lot of times they'll describe it as a cramping pain after they've walked a certain distance. Or they may get pain at nighttime where it's just a severe cramp that's not relieved until they can put their leg down on the floor. Usually it's more of a burning sensation at the foot, but it's relieved with hanging the legs down. That means you have pretty severe blockages in the arteries. The other thing that diabetics will tend to have is they can get a lot of wounds, and that's for a couple of reasons. One, diabetics develop what we call neuropathy, meaning that they will get numbness in their feet and their hands. A lot of times it may just be the numbness like your legs are asleep. A lot of times it will progress into a painful numbness. But because of the numbness, if a diabetic steps on a rock or, God forbid, a tack or a nail or something, and they won't feel that at all. And so eventually they will develop an open wound or a sore. And then they also have lack of blood flow because of the blockages that diabetes contributes to. And so those two things combined, they develop a sore. They don't know it's there until maybe a family member sees them. The other thing is that because diabetics tend to develop trouble with their eyes and cataracts, they have trouble seeing with retinopathy. They don't even see that there's a wound on their foot. So there's a lot of factors that go into that. And then what can happen is if it goes on for a long period of time and nobody notices it, they may end up getting gangrene and may end up needing amputation. So diabetics really need to have very good foot care and never go barefoot. Never.
I heard a story about someone who had diabetes, and a child, one of the grandchildren, put a coin in his shoe. Just dropped it in there, and he's walking, and he never felt it.
Right.
And then there was a sore, and so that's what you were talking about.
Right, because it will rub in the shoe and then just break down the skin. And because of the decreased blood flow, because of the artery disease, the neuropathy with the numbness, there's all these factors combined can lead to a very long period of recovery, actually.
Well, it sounds like this is a very big job, and there must be a lot of people who need you. But let's get back to you personally. So how long have you been doing this, and why did you decide, of all the various specialties, why did you become a vascular surgeon?
Well, I've been in practice for 13 years, going on 14 years now. when we do our training in medical school, we rotate through different fields, and I really liked the vascular surgery field. It's the big thing that I liked about it is that there's a lot of continuity of care, and I really get to know my patients. I see them on a yearly basis and continue to follow up with them, and I really liked that aspect of it. There's few areas in surgery where you keep having that continuity of care, so I like that a lot. I also like the surgery itself. It's very delicate, and we have to wear magnifying glasses in the operating room sometimes, and so it's a fun surgery to me. So that's why I chose vascular surgery. But after my medical school, I did my residency and training down here in Miami at Jackson Memorial. And everybody knows how great that place is. And the experience that you get there really is second to none. There's a lot going on down at Jackson. And I had great teaching. Did a lot of surgery there. And then I went on to do my vascular training at the University of Maryland. In Baltimore. I stayed on there as a staff member, as a professor there for 5 years, and I really had a big focus on vascular disease and women, because it is an area that's really under researched in women. Men always get the attention when they're doing the research, but now we're really bringing up the differences with women.
And there's
a lot of differences, actually, and it's going to sound a little cliche, but part of it is that women are the ones who are always taking care of everybody else in the family. So when they get leg pain or they have something wrong with their legs, they say, "Oh, I'm just getting older. Oh, I still have to take them to their appointments. I have to do this. I have to pick up the kids." So the women really don't come to see the doctors. And what ends up happening is that they go down the line and progress so far that sometimes they've progressed too far, and the only option we have is amputation. So I did a lot of community outreach, a lot of health fairs. I got my master's in public health while I was there, and really
busy girl.
I really tried to get the word out that women really need to pay attention to their bodies and put them a little bit in the front as well, and come in and get things checked. So that was my main focus when I was at the University of Maryland.
Well, you don't know this, but my husband built Columbia, Maryland with James Rouse.
Oh,
and
yes.
so that was back in the 60s. But that certainly, they were very ahead of a lot of things, having John Hopkins working with them. But I just threw that in. It's okay. But I was thinking as you were saying that, and I put my gerontology hat on, that we always say, very much like on the airlines, take care of yourself first and then put the oxygen on the person you're with.
Yes.
And so we know caregiving, so many times the caregivers themselves die before the person who is so sick.
Yes,
because of what you just said.
Right. Always focused on other people.
But now standing here, you have made, it's funny, as long as I've been doing this, and I have a sit-stand desk because I don't want to have back problems, and I don't. So I have one where I stand, but I don't know. I thought it was fortunately I stand a lot more than I sit because I think it's better for me. Well, now I'm going to do a lot of exercise. So standing here, I have to be doing it. And when I'm doing that with my legs, what I'm doing then is making the valves
You're making
open.
the blood. Yes, you're pushing the blood out of the legs. So it helps to prevent any of that vein disease from happening. And that's what I tell my patients as well. If you find yourself standing in the grocery line, or you're Christmas shopping and you have to stand for hours at a time in line, make sure you're moving around. Just move your feet up and down, back and forth. Try to walk in place to keep that muscle pump activated, keep that blood circulating. That will help a great deal.
Well, so you've been practicing. So you start 14 years. So my question is, things have changed a lot from when you first started. You talked about some of the stripping, but let's say 50 years ago, probably people didn't even have anything done with this.
No, a lot of people didn't want to deal with vein problems, actually. So a lot of doctors just said, "Oh, that's varicose veins. It's cosmetic. There's nothing to do." It was sort of the stepchild of the vascular world. Nobody wanted to deal with the veins. But nowadays, people are understanding that it is a real medical problem. People have pain. They can't go to work. They can't stand for long periods of time. They have itching or burning in their legs, and they don't know where it's coming from. And the itching, burning happens because that blood that's sitting down there stagnant has some I would say, in quotes, toxins that can cause that kind of stuff. And that's why some people will have those symptoms, and they have the tiredness, the achiness. And with just a simple endovenous procedure with the laser or the RF, it really is very, very lifestyle changing for people. Some people don't want to go through a procedure and they just wear the compression socks and they can see the same results as well. So it just really depends on what you want to do.
And I know there are different degrees of compression stockings.
Yes.
And we have to go through that because I did once buy some compression stockings, but it was the least amount. But even they were hard to put on.
Yes, so they are a little
Do you have any help for us?
They are a little bit difficult to put on. The best way to put them on and to get the most out of them is to put them on in the morning before you get out of bed. Because remember, the minute your foot hits the ground, if you've got broken valves, all that blood is going to rush down to your feet. So if you spend 5 minutes brushing your teeth, another 10, 15 minutes in the shower, another 15 minutes eating breakfast, and then you go to try to put on your socks, you're already behind the 8 ball. So if you can put them on in bed before you get out of bed, that's the best. Now, my patients will say to me, but I want to take a shower. I said, of course you want to take a shower in the mornings. If you really can't change your routine in the morning, what I recommend is take your shower, get back into bed, try to elevate your leg for a good 20 minutes, and then try to put your sock on. So that's one thing that will help. The second thing that will help is that there's all sorts of things that we call donners that you can get at the medical supply store. The simplest thing is actually just kitchen gloves. Rubber gloves help to roll that sock up. But there are a couple of other things that the medical supply stores will sell that will help to hold the sock open where you can put your foot in and then pull the sock up. The other thing that a lot of people don't realize too is that you can get custom stockings. They are quite expensive, but for people who really need it, if they've had an ulcer or they really need the compression and they're not a candidate for any procedures, you can make them with a zipper, and then you can just zip them up, like a pair of pants. That makes a lot of difference for some people.
I hated to take your valuable time on this, but I think a lot of people who are listening have learned a lot about this.
Oh, I hope so.
Because, as a surgeon, there's so much more to talk about, but those are the simple things. So now you send someone home and you say, all right, just get compression stockings. And I know enough about you, Dr. Cheanvechai, that you wouldn't do that. You would probably help them. Probably in your office, you're going to show them. But anybody else who maybe has this problem and they've gone to some other surgeon, so probably has not had that instruction. So that's a very, very good point. Well, let's get back. When you first started, you talked about vascular disease, stroke. Tell us about how that all comes into play.
So you can get strokes for a couple of reasons. One big reason is that you can have bleeding in your brain, and that's called a hemorrhagic stroke. That can happen from high blood pressure. Sometimes it can happen depending on blood thinning medicine that you might be on. The other reason you can get a stroke is that you may have blockages in the neck arteries. The neck arteries are called the carotid arteries, and they lead directly up to the brain. So you can imagine if you build up plaque or blockages in those arteries, that plaque is not smooth. It actually has a lot of pits and craters in it, just like the moon. And so as the blood flows by those plaques, it can dislodge some of that little debris, and that's what goes up to the brain and causes a stroke. It'll block off one of the arteries in the brain. So the symptoms of stroke are not being able to move your arms or legs, not being able to speak, and there's two things when you're talking about speech. It may sound garbled or slurred, like you may be drunk, somebody may not understand you, or you may have trouble getting the right words out. So you in your mind know what you want to say, but the words come out all mixed up. That's also a sign of having a stroke. So a lot of times it's the people who you're talking to who will notice it. The other symptoms can be very simple. You may have some visual changes, and this is another symptom that a lot of people don't know about. But if a little piece of debris goes up to a certain artery in your eye, you can have what we call a blindness in one eye, and it's temporary because then the clot kind of washes away, where it looks like a shade is coming down, and then it lasts for a few seconds, and then it'll go away. A lot of times the ophthalmologist might also be able to see some of these plaques on their retinal exam, and then they'll send them to see a vascular surgeon or somebody who can take care of it. But those are all symptoms that you may have what we call either a mini stroke or a TIA or a full-blown stroke. But anytime you have symptoms like that, you should definitely go to the nearest emergency room so they can check you out.
So does a primary care physician, when you just go for your yearly checkup, will he be able or she be able to see things that would be suspicious?
Yeah, not necessarily. Most people who have carotid disease or blockages in the carotid arteries usually have no symptoms at all. And what a physician can do in their office is that they can listen to your neck arteries, and sometimes you'll hear a certain whooshing noise in the neck arteries. We call that a bruit. Now, that sometimes means that you have plaque. Sometimes it means you don't have any plaque, but it is sort of a instigator to start doing some testing. And then the first test we would do is an ultrasound. Again, very simple, no poking, no pinching, just an ultrasound of the neck arteries. And usually you want to have it done where there's a vascular technician, because there's a lot of intricacies with the vascular system in doing that kind of ultrasound. So you want to make sure that they're a vascular trained ultrasound technician, or the doctor's trained to look at the study or read the study. And then depending on what we see on those ultrasounds will dictate what you do afterwards. So sometimes you'll get blockage up to 50%. Usually 50% or less, there's really nothing to do. We just check it on a yearly basis. Then the next category is 50 to 70%. Again, if you're not having any symptoms, usually nothing to do. But if you're over 80%, then that's when you got to start thinking about, what can I do to take care of this?
I'm Anita Finley, and I'm the host of the show, and I'm having a wonderful conversation with Dr. Vasana Cheanvechai, and she is practicing at the Broward Health Imperial Point. We're very happy she's here today. We're learning so much from her, and I have to just say that the word minimally invasive now is happening everywhere. So don't be afraid of a lot of the things we've been talking about. First, you have to go and get real specialized indications that there is something more serious. We're not trying to just scare people, but I think if you make sure that if you're having any of the problems that Dr. Cheanvechai talked about, well, then it is suspect. But if you're not, just make sure that you go. First of all, we want you to stop smoking. Yes. We want you to have a good diet. We want you to exercise. And if you're standing for a long time, as I'm doing now, you're going to make your feet go. And then on planes, you're going to have compressed stockings. How'd I do? I learned a lot, didn't I? Yes. Well, Dr. Cheanvechai, it was so nice to talk with you. And I'm certainly know why your patients love you. I can tell already.
Well, thank you very much for having me here.
Thank you.